I'm Dr. Ravi Landge, a general and laparoscopic surgeon. The title of my topic is Preventing a Surgical Catastrophe, Performing Safe Laparoscopic Cholecystectomy in an Anatomical Vascular Variant. 43-year-old male. He had come to us with a pictal catheter tip in situ. He had underwent a cholecystectomy procedure in a private setup. Though the details of cholecystectomy are not available with us. This patient had continuous biliary drainage from this pictal catheter tip and he had discomfort because of it. Patient had severe abdominal pain like 2 months back, for which he went to a private setup in Mumbai. There, this cholecystectomy procedure was performed. On examination, patient was vitally stable. His per abdomen findings were like his abdomen was soft. There was no tenderness, guarding and rigidity. He had a pictal catheter tip in situ with approx of around 100 ml of bile drainage output per day. His labs revealed hemoglobin of around 10 mg per dl. His LFT was normal, alkaline phosphatase value was normal, his PTINR was within normal range. His review USG was done, which revealed the pictal catheter tip in situ in the gallbladder. So, the treatment plan for him was to perform a laparoscopic cholecystectomy. Priority was to be given to identify the critical view of safety and then only to ligate and cut the structures. So, laparoscopic procedure was started for this patient. We removed the pictal catheter tip under vision. The gallbladder was identified and it was densely adhered to the surrounding structures. The anterior and the posterior peritoneum was dissected off. The calyx was exposed. And when we exposed the calyx triangle, it was seen that instead of 2 structures, there were three structures which were entering the gallbladder. So, I refrained from ligating or clipping any structure. So, at this moment, what I did, I dissected off the vessel cranially and parallelly to the vessel, and it made the vessel fall more of medially near the liver. And later, during my dissection, it was revealed that it was not the cystic artery which I was dealing with, it was rather the right hepatic artery which was branching off. Hence, a vascular catastrophe was indeed prevented. The aberrant right hepatic artery and its branches were safeguarded, and the potential vascular complication and the ischemia arising because of it was totally prevented. Talking about the discussion part, advantages of laparoscopic surgery. Patient has less pain, there is faster recovery, surgeon has a very good vision, and there is reduced morbidity versus the traditional open surgery that we do. In calyx triangle are common, and identifying them can significantly reduce the risk of vascular or bile duct injury during the procedure. Identifying the critical view of safety, following the culture of safety in cholecystectomy, that is calling some other surgeon who is not directly involved in surgery to show the anatomy before we either ligate or clip any structure and cut it. And also following the doublet sign, that is seeing the critical view of safety not only from the anterior aspect but also from the posterior aspect before we ligate or clip any structure and we cut it. Strict adherence to these protocols definitely decreases the risk of potentially life-threatening complications. This underscores importance of careful dissection, anatomical awareness, and not assuming a standard anatomy in every patient. Thank you.